Thanks to the organizing committee for the invitation to speak. I'm primarily a clinician. I hope that there will be some relevance for those in the audience, as I think much of what I've seen today is basic science. So I'm speaking about the application of systemic interferon alpha 2b in the treatment of refractory uveitic cystoid macular edema. Cystoid macular edema is a complication of uveitis that can affect up to 30% or more of all comers who experience uveitis or intraocular inflammation. And it involves a thickening and cystoid collections of fluid in the retina. And it can be a leading cause of loss of vision or legal blindness in these patients. And unlike other causes that cause decreased vision in uveitis, such as cataract, it may not be reversible if it's not addressed in time. Interferon alphas are species-specific cytokines that are produced by white blood cells. They have antiviral, antiproliferative, and immunomodulatory properties. They're used clinically in chronic hepatitis, Hep B and C, leukemias and lymphomas, and other solid tumors such as melanoma. The first ocular use came about looking at Behcet's disease that causes a very severe posterior and panuveitis. The Europeans were far ahead of us in using this in ocular inflammation. This group in Germany treated 50 patients with Behcet's panuveitis, had a 92% response rate to interferon alpha systemically delivered subcutaneously. The visual acuity improved significantly, and then they noticed that in a subgroup of eyes, 58 with cystoid macular edema, so a good percentage of the eyes, all of that fluid resolved with treatment. Others looked at a dose escalating protocol for systemic interferon treating Behcet's panuveitis, and found that it was similarly effective if you start with low doses and gauge for response and then up the dose as needed. And this is important because the side effect profile is tremendous with this drug. And then others in the UK looked at non-Behcet's related uveitis, and again, from other causes, they found that it had high efficacy in controlling the uveitis, and importantly for this talk, in the 14 eyes with cystoid macular edema, they noticed 100% resolution once again. This is the table 3 from their paper, shows the side effects that were noted in their patients, and you can see it's a considerable list. So Manfred Zierhut in Germany, his group again, the group that discovered that this had such strong efficacy against Behcet's panuveitis, wanted to look at refractory uveitic cystoid macular edema in patients with a history of uveitis of all comers to see if it would also be effective. And they did a pilot study of 8 patients, 15 eyes. These patients had fluid in their retinas for nearly 5 years, or a little over 4 years, 52 months. And that's an enormous amount of time. And you can imagine during that time they'd been treated by multiple different therapies and were refractory to most, if not all of them. They noted in 13 of the 15 eyes 100% resolution. One patient, 2 eyes, had no response from the beginning, and they later detected circulating neutralizing antibodies against interferon alpha 2A, and hypothesized that this patient, for whatever reason, could not mount a response to drug. And 1 of 7 lost the response, and in that patient, again, there were neutralizing antibodies detected against the exogenous interferon. So of the 11 eyes that made it out to 6 months, the mean central macular thickness decreased from 551 to 143, and the visual acuity nearly doubled. They did a follow-up study of 24 consecutive patients, 40 eyes. These patients had cystoid macular edema for 36 months, and they had very stringent criteria for effective. They included only those patients that had 100% resolution of fluid, and they also had to be able to taper them off the interferon. And so many, and that was 63%, and then another 25% were partly effective, but in that group, many of those had near complete response of their fluid. They just couldn't come off the drug. So in my fellowship in Oregon, I, along with Jim Rosenbaum and Eric Suhler, wanted to see if this would be effective in our patient population in the U.S. We didn't have interferon alpha 2A available like they do in Europe. We have interferon alpha 2B, its closely related cousin. We presumed it would be effective, but no one at the time was using this drug in this application. And in a period of about 2 years, we enrolled, we treated 4 consecutive patients with this drug. This was just a retrospective consecutive interventional case series. And all patients treated were included in the analysis. These are the patients. They were all female, just by coincidence. You can see the numerous treatment failures for all of them. Many of these are local treatments like the fluoroquinolone implant or Retisert, Ozurdex is dexamethasone implant, systemic medications as well. And they all had chronic cystoid macular edema on average for 31 months. In red, we have the baseline thickness of the central macula of 563. Within 2 to 3 weeks, it was down to 299, and by last follow-up, it was 267 for all 8 eyes. And the visual angle in our cohort, again, nearly doubled from 0.81 to 0.45. Pictures, of course, are worth 1,000 words. So here are the patients. For those of you that are not clinicians, these black fluid-filled spaces are the areas of pathology, the cysts that are accumulating as a result of the leaky blood vessels from the uveitis, and that will destroy your vision if left for a long period of time. So patient 1 at baseline, and then at 3 weeks you see a nicely restored foveal contour here. Patient 2, an enormous amount of fluid in the right eye, less so on the left, but nearly completely gone within 2 weeks. In 3, this patient had worse fluid in the left eye, a little bit in the right, but again, minimal by 2 weeks. And patient 4, again, dramatic response. There's the Logmar vision plotted with time. They all improved. So is it a wonder drug for this application? If you just look up the Micromedics list of side effects, this is what comes up. So it's not a wonder drug. It has application for sure, but the side effect profile and adverse event list is considerable, and so it's a very, very careful risk-benefit analysis that one needs to make to decide to proceed with this therapy. A couple that I'd like to highlight, one is fatigue and flu-like illness. Virtually everybody should feel this. If they don't, they probably have pre-existing antibodies against the exogenous interferon, and they probably won't respond favorably to the treatment. Weight loss is very, very common. Liver enzyme elevations I see commonly. Suicidality is important to talk to your patients about before proceeding with this treatment. Anybody with a history of depression could be tipped into a suicidal state. And then sarcoidosis is interesting in that this drug has been implicated in exacerbating sarcoidosis. Many of our patients in uveitis have what we call now undifferentiated uveitis, where up to 50% of the time we don't find the underlying cause, but presumably there is something there. And a good percentage of those may in fact come to have sarcoidosis. So I'm always thinking about this in the back of my mind. Could I be exacerbating a systemic disease? Ocular effects, of course, we're asked commonly by our hepatology colleagues to monitor their hepatitis patients who are taking interferon for retinal vascular problems. Interestingly, in all the patients that were treated with this drug for an ocular intention, I saw no local adverse effects in the eye, and none of the patients I've treated have experienced that either. That's the side effect list of those 4 patients I presented. They all had considerable side effects. So in the past 3 years, I've come to Johns Hopkins, and to give you an idea of how frequently I use this, I've treated only 3 patients. And so it's not the treatment of choice for everybody. You want to proceed in a stepwise fashion, using safer drugs first. This is my experience here. This is a 30-year-old African-American male who was referred to me for retinal vasculitis. His workup was non-contributory, meaning he had no identifiable underlying systemic disease. And before referral, he'd had 15 months of chronic uveitis with macular edema, optic nerve swelling. It was refractory to high-dose prednisone, local steroid injections, which I tried with him. I also gave him Avastin. It was not effective. Here he is on presentation. His vision was 20/80 and 20/50 in the left eye. Central foveal thickness, very, very thick. And I gave him interferon after trying several other options first. And there he is after 1 month of therapy, and vision starting to improve. The visual acuity often responds later, depending on how long the fluid has been sitting in the retina. And his central foveal thickness was much improved. However, he'd been hospitalized 3 days prior to his visit with me for profound neutropenia. He had hypokalemia. He was vomiting. He had lost a lot of weight. He had missed a lab draw, this was the first patient I treated here at Wilmer. I've now instituted a different lab following program with my technicians to be sure we don't miss these patients. So we tried to treat him by other methods over the following 3 months because he'd had such a bad reaction, and he was not really doing very well. And eventually I paired up with his hematologist who was consulted when he was admitted for the initial complication. And we've been able to manage him well with a lower dose of interferon and Neupogen. And his last follow-up, he's been on the drug now for about a year. He's down to 1 injection a week. We start with once a day, and he's doing really remarkably well and has had no further complications. My second case was a 7-year-old Caucasian female referred for steroid-sparing therapy for retinal vasculitis complicated by cystoid macular edema. She developed floaters, loss of vision associated with uveitis several weeks after cataract surgery, and she was diagnosed with retinal vasculitis and this complication. My workup with her, again, she had undifferentiated uveitis, posterior uveitis, and there were no known causes of this. She had failed previously intravitreal triamcinolone. Although it worked temporarily for her edema, her pressure her eye pressure shot up to the mid-40s, and the edema recurred. She'd failed Avastin. Diamox gave her a lot of fatigue, and it didn't seem to work well for her edema. And prednisone worked, but it recurred at 20 milligrams, which is unacceptable. I put her on methotrexate as a steroid-sparing option, and her uveitis came under good control, and we were able to taper the prednisone, but the cystoid macular edema persisted. I added Durezol, which is a strong local topical steroid, and that also was not effective. It was partially effective with the edema, but she had, again, intraocular pressure spikes. So here she is prior to starting interferon and 3 weeks post. But again, like my first patient, there's a caveat. She was admitted a month later after starting with pulmonary embolism, and this is listed as a rare association with the drug, but like many of those side effects I showed you, anything that could possibly be reported in connection will be reported, so it's hard to show causality. I spoke with her hematologist, and she felt that the patient has other risk factors for pulmonary embolism, and so we cannot definitively prove causality, and that if her eyes warranted continued treatment and the risk-benefit was in favor of continuing, she was on board with it, which we've done. And she, again, has done very well. She's down to every 4th day. She has no fluid in her retinas, and her vision has improved. And my last case, a gentleman, 51-year-old African-American, who was receiving 8 injections of steroid per eye per year. So That's a lot of therapy. Injections are done commonly in ophthalmology, especially now with macular degeneration treatments, and the incidence of infection appears to be low, but we have to remember the burden to the patient undergoing these injections. It's not easy to come in for that many procedures. And I put him on interferon ultimately, and he's done very well. But again, he also has had a drop in his white blood cells, and in particular the neutrophils, so we have to follow him closely. The mechanism is really not known. It's thought that this is a consequence of abnormal blood vessels that have been damaged over the years by chronic inflammation. But in general, all of these eyes have burnt out or controlled inflammation, or uveitis. It's a leakiness at the level of the endothelium. There was an interesting paper in 1995 put out talking about how interferon alpha 2b enhances barrier function of bovine retinal microvascular endothelium. And they concluded that it can enhance the barrier function of the microvascular endothelium. It may have therapeutic potential in diseases characterized by leakage in the retina. So to conclude, interferon alpha 2b appears effective for this indication. It has a considerable side effect profile, so it involves careful risk-benefit analysis. Importantly, most of the side effects are not treatment limiting, so patients feel lousy on it, especially for the first week or so, but none of my patients have asked to come off it because it improves their vision and in some cases saves their vision. I've seen some patients whose options appear to be limited to just this option. And so you want to carefully select the correct patients for this indication. Those that are refractory to intravitreal steroid may be an option, or those in whom it's contraindicated, so fragile glaucoma with a history of steroid response. And I'm happy to see your patients if you feel you have somebody who may benefit from this treatment. Thank you very much.
Any questions?
How do you inject the interferon? Intravenous or?
So it's subcutaneous, and the patient self-injects, and we teach them in the clinic if they have no experience, or sometimes I ask them if they have a family member with diabetes or something like that who can help them.
Yes.
Follow on to that, can you inject into the vitreous?
Right. So that's something we're actively pursuing now. It is a protein, so it will suffer from, I think, the same problems as avastin and others, that in terms of half-life and fragility in the eye. But there's only one case report I've seen coming out of South America. They injected it subtenons for diabetic macular edema, and it was a single case report, and it appeared to be effective. But so far I haven't seen anybody report on injecting in the vitreous. Years ago, a decade ago, there was some potential that this drug in a systemic form may have benefit for the exudative form of macular degeneration. And a big trial failed and showed that it wasn't effective. But at that time, other groups were investigating the safety of this drug intravitreally, and there were some reports of ERG changes in rabbits. And so I think a lot of investigators are reluctant to go forward with humans because of those reports.
I hope that pegylated interferon may work intravenous.
Yes, pegylated interferon appears to work as well. There's no data on it. That's anecdotally, I've heard that from one of my co-investigators.
Right.
But it appears to work as well with a better side effect profile.
Thank you.
I was under the impression that the 2B is always pegylated here in America.
No, it's not. Yeah.
Let's thank our speaker.
Thank you.